Good afternoon, everyone. My name is Hillary Michael, and today we will be talking about treatment basics for pediatric inflammatory bowel disease. The objective of today's lecture will be to discuss the goals of treatment in pediatric IBD, to outline the stages of IBD treatment, and to review some of the most common treatments for pediatric IBD. Now, before we get into the meat here, I want to quickly review two slides from the prior talk about IBD basics. First of all, what is IBD? It is a group of chronic inflammatory diseases of the GI tract. And the most common types that we will address today are Crohn's disease and ulcerative colitis. I also want to hit on this slide because the causes of IBD directly impact the way that we treat it. Now, genetic predisposition and environmental triggers were not great at adjusting, but you will see as we move forward that some of our treatments affect the microbiome, so the bacterial makeup of the gut, and some of them address the inappropriate immune response that patients with IBD have. So what are the goals of IBD treatment? Well, there are many. First of all, we want our patients to feel good. We want to control symptoms, relieve symptoms, improve quality of life. We want our patients, especially in pediatrics, to have normal growth and development. We want to minimize treatment side effects while maximizing adherence. We want to heal the intestinal lining or heal the mucosa. We want to prevent disease-related complications. And in the end, we want to alter the natural history of the disease in a favorable way. So before we dig into the types of treatments, I want to hit on the two main stages of treatment in IBD. And in this graph on the right, you can see that time is on the x-axis and disease activity is on the y. And so there are two main stages that we treat IBD. One of them is induction. And this is when the disease activity is high, either at time of diagnosis or at time of disease flare. And induction therapy is typically short, 8 to 12 weeks in duration. Then there's maintenance therapy, and the goal of maintenance therapy is to keep the disease quiet, to keep it in remission over the long term. So now let's dig in. One of the most well-known treatments for IBD is corticosteroids, or are corticosteroids. They are indicated for induction therapy in Crohn's and ulcerative colitis, and they work by broadly suppressing the immune system. They come in multiple formulations. There's systemic corticosteroids, which come in both oral and IV forms, things like prednisone or methylprednisolone. And then there are more topical formulations that come in both oral and rectal versions, and that's your budesonide. Now, the pros of corticosteroids are that they can get patients feeling better quickly, and that's a great thing, one of our goals. But the cons are many. Steroids have a ton of adverse effects, including but not limited to the ones that are listed here. And so when patients are on corticosteroids, we have to monitor them closely for these complications. And all of these complications are what takes us to our take home about steroids, which is that they're for induction only, short-term therapy, get patients feeling better to get them onto their maintenance therapy. Now, how about 5-aminosalicylates? 5-ASAs are indicated for induction and maintenance therapy in mild to moderate ulcerative colitis, and they work as a topical anti-inflammatory. They come in both oral and rectal formulations, and there are multiple different types, and this figure on the side can show how different types release at different places in the GI tract. So depending on where your patient's inflammation is, you can select a medication either by mouth or rectally that hits the areas where the inflammation lives. Now, what's good about 5-ASAs? One of the best things is that there's no systemic immunosuppression. I often describe these as like a topical cream for the lining of the GI tract for the colon. But there are some cons. One of the biggest ones is actually the dosing. So the way that the dosing is recommended for many of these is very burdensome, frequent dosing with many pills per dose. There are also some adverse effects that patients experience, including GI distress, headaches, pancreatitis, an idiosyncratic reaction where the GI symptoms actually get worse after starting the 5-ASA, and then rarely nephrotoxicity. In terms of monitoring, mostly it's for the symptoms that are listed above. Some docs will also get an annual urinalysis to look for that nephrotoxicity. And a practical note here is that the oral formulations work well, the rectal formulations work well, and if you're having a patient who's not quite getting there, you can combine them for an optimal response. Take home here, simplify the dosing to optimize adherence. So even if the formulary says give the 5-ASA 4 times a day, clump them into BID dosing to help your patient take their meds every day. All right, so next on to methotrexate. Now methotrexate is indicated for maintenance therapy primarily in Crohn's disease, and it's an immunomodulator. It inhibits DNA synthesis and repair, which helps prevent that overactive immune system in inflammatory bowel disease from doing its damage. It comes in oral and sub-Q formulations primarily, also IM, but most patients don't use that, and it's dosed weekly. Now, the adverse effects here, the common ones are nausea and vomiting, headache, and malaise, just feeling kind of crummy. And then there are less common side effects that include bone marrow suppression, liver irritation, and pulmonary toxicity very rarely. So because of that liver and bone marrow suppression, we get routine blood counts with a CBC and ALT measurements, especially soon after starting the meds. Once we see that a patient is tolerating it for a few months, those lab checks can be spaced out further. A few practical notes about methotrexate. It inhibits folate metabolism, and so folic acid should be administered 1 gram daily. It does take time to work, about 2 to 3 months, which is why it's more of a maintenance therapy typically. It can interact in a negative way with alcohol, and so combining these two is a no-no. And then finally, it's a potent teratogen for female patients. So if you're starting this in a female patient of childbearing age, you really need to talk about contraception. Take home for methotrexate, it is only useful in Crohn's disease, not a treatment for ulcerative colitis. Now on to our next medication, 6-mercaptopurine and azathioprine. Now these two medications are also immunomodulators, indicated for maintenance therapy only in Crohn's and ulcerative colitis. Both are oral, and they work as purine analogs. They inhibit DNA and RNA synthesis, again, preventing those overactive white blood cells from doing their damage in the bowel. Now, I like this flow sheet because it shows you the metabolism of the medication, and you can see the azathioprine here is a prodrug to your 6-mercaptopurine. And then these drugs break down into 2 main byproducts, 6-TG, 6-thioguanine, which is the active metabolite that actually gets into the DNA and inhibits DNA and RNA synthesis. And then there is 6-MMP. This metabolite is really just a byproduct that at high levels can cause issues that we'll talk about soon. So before you start 6-MP or azathioprine, it's important to get a lab called the TPMT activity. And you can see that enzyme here, thiopurine methyltransferase, as part of the breakdown and metabolism of the drug. You need to know how active that enzyme is in your patient to decide how to dose the medication. So along those lines, there are some dose-dependent adverse effects in 6-MP and azathioprine, and those include myelosuppression if your 6-TG level is too high, and hepatotoxicity if your 6-MMP level is too high. So as you might imagine, monitoring for these include blood counts and liver numbers, specifically the ALT. And again, just like methotrexate, you do this more frequently soon after starting the drug, and then space it out thereafter. You can also specifically order 6-MP metabolites if you're worried about drug toxicity, if you're worried about adherence, and you can see if there are actually the metabolite levels in the blood of your patient. And then finally, if you're worried about inadequate response. In addition to the dose-dependent adverse effects, there are some dose-independent adverse effects to watch out for with 6-MP and azathioprine. Those include pancreatitis, flu-like illness, and GI distress. We can also see an increased risk of hemophagocytic lymphohistiocytosis, or HLH, and some malignancies, including non-melanoma skin cancer, lymphoma, and a very rare but very severe lymphoma called hepatosplenic T-cell lymphoma. Now, these risks are small, but it's important to talk about with your patients as you start these medications. The take-home message for 6-MP and azathioprine I'd like you to remember is that checking TPMT activity is very important to help with appropriate dosing to avoid those dose-dependent side effects that we talked about. And then the last medication I want to touch on is the family of medications called Biologics, and there are many. But for this talk, I want you to know that Biologics can be used for induction and maintenance therapy in moderate to severe inflammatory bowel disease, and also in inflammatory bowel disease that involves growth or pubertal failure, and also Crohn's disease that is fistulizing or perianal in location. And the mechanisms vary depending on the biologic, but uniform to all of them is that there are antibodies that block certain steps in the overactive inflammatory cascade. They come in both IV and sub-Q formulations depending on which drug. And the pros of them are that they do a great job healing the mucosa, healing the lining, and they can do a really good job improving growth in those patients with growth and pubertal failure. Now, the cons are cost. These are one of our most expensive meds. They can be inconvenient because they involve injections, IV placement, visits to the infusion center. Because they have an immunosuppressive effect, they can increase the risk of infection. And there's also, for some of them, a slightly increased risk of lymphoma. Now, my take home for biologics are that they're antibodies that selectively block portions of the overactive immune system pathway. And finally, you remember at the beginning, the microbiome was one of the causes or contributors to the development of IBD, which leads me to talking about exclusive enteral nutrition, which is a dietary therapy for certain patients with IBD. It's indicated for induction therapy in Crohn's disease. And again, the thought is that it alters the microbiome in a way that decreases inflammation. How does it work? Well, patients on exclusive enteral nutrition get 90 to 100% of their calories from formula during that 8 to 12 week induction period. Most of our patients drink the formula with the resulting or the residual 10% of their calories coming from food, but some patients also will have an NG tube and will administer the formula that way. Pros to exclusive enteral nutrition primarily are that it really improves symptoms and can heal the mucosa. There are very few side effects, and importantly, there's no immunosuppression. It's just dietary therapy. The other big pro is that it can really help weight gain and growth in our patients that struggle in that category. But the con, of course, is that dietary therapy is hard, and only drinking formula for 8 to 12 weeks is really challenging. But we have excellent dietitian support, and this is something that we have done a great job with at our center. And then last but not least, I want you guys to remember that surgery is a part of comprehensive IBD care. A lot of our patients, not all of them, but many will need surgery. And the reasons for this may be medically unresponsive disease, complications of IBD like obstruction, abscess, or fistula, growth failure, and rarely, thankfully, in pediatric IBD, dysplasia or cancer. Now, a lot of our families will be worried about surgery because they assume that it automatically means their child or they will need an ostomy. And one thing that I really like to emphasize with my patients is that a well-timed elective surgery may be able to help the patient and avoid an ostomy from the get-go. And so my take home on this slide is that surgery is not a failure or a last resort, but it's a very important part of IBD care for a subset of our patients. And so in conclusion, the goal of IBD therapy are multiple. We want to treat symptoms and resolve them. We want to have our patients grow and develop normally, and we want their mucosa to heal. There are two main phases of IBD treatment: induction, which is meant to calm down the inflammation and help with initial symptoms, and then maintenance therapy, which keeps the inflammation quiet and keeps the bowel healed. And finally, we have a varied but limited arsenal of therapies for IBD, which include medications, nutritional therapy, and surgery. Thanks so much for your time today. Hope to see you again soon.